hold it like this position behind the back. Okay, and then first we have to slump the trunk first. Okay, so upper trunk and lower trunk. Okay, then slump forward. Okay, and then just hold it. Are you okay? Okay, so just do it gently. Okay, and then maintain the posture. Okay, and then you just take your forearm to get aligned with the spine. Okay, and gently what you do is try to, so you don't push too much down, the patient will fall down the other way. Okay, so you have to do it very gently and make comfortability, because it depends on the flexibility of the person. Okay, so sometimes the patient cannot able to go this much. After this case, they cannot able to go because it depends on the flexibility of individuals. Okay, so for him, he can able to go. Is it okay, right? So always talk to the patient. They're comfortable. That's very important. Okay, then hold this position. Okay, so then bend the neck. Okay, now you passively what you do is straight the knee. So since he is bent too much forward, so it looks like there is a tightening structure. So he cannot able to extend the knee more than 10 degrees from there. You see? 90 degree, you cannot able to go. Even an active also you cannot able to go. Okay. So this indicates where is your pull? Over here. So sometimes it could be a hamstring tightness, or it could be a neurological, let's say like flexibility also differs. So we have to test that. Okay. So again, I'm just going to do one more time. Okay. So just hold it. Okay. And then slump the posture, thoracic, lumbar, and then hold it. Okay. And add the neck movement. Okay. And passively just hold it. Okay. Then you just try to do the dorsiflexion. Okay. And then you just do passively you see here there is no range after this. There is your, say like there is a resistance over here. Okay. So what is your response you are just getting? You pull over here or around the legs. So usually if there is a neurological symptoms, so it's say like it will go down as well. Sometimes with the patients, they have hamstring flexibility is less, then they may be experiencing this symptoms to be positive. Okay. Then we have to check on the both sides. Check on the both sides. Okay. So usually for the testing side, we have to go to the other side, then we have to perform. Okay. Compare on both sides. Okay. Sometimes the right leg will be normal for them, or left leg will be affected for them. So we have to check on that. Okay. So this one when we check, so it's a like basic one. If there is a side nerve involvement, it could be a positive. If there is a spinal cord compression, it will be positive. Okay. Sometimes the nerve compression also gives a positive signs. Okay. The next is for obturator nerve. So for the obturator nerve, so the patient position is slightly vary. So what you do is you have to like this. So you just make the patient to get facing in the corner like this. So you see here, your face will be facing like this, and then wider your legs. So this one, you just make the obturator nerve to be get stretched. Okay, and we do the same procedure. Okay, so you just therapist can stand like this. Okay, slump the posture, and then you just maintain the neck flexion. Okay, then you just do with the dorsiflexion, we do the extension. So again, he has but comparatively this differs. He has more movements compared to that, right? Do you feel this? Feel that?
I feel all the way down.
Okay, so you can able to check his obturator nerves comparatively better compared to the sciatic nerve flexibility. Careful. Okay. You have instruments, right?
Yeah.
Okay, so we can able to find the difference. So the obturator nerve is flexible compared to the sciatic nerve for him. Okay, so the next is we just go for, so we are testing the obturator nerve in this position. Okay, go for side lying. So side lying is, okay, so we are going to test for the femoral nerve. Okay, the patient position. Okay, so can you bend. Okay, slam and just hold it over here. Okay, and then you just try to come inside actually. Bend. Yes, fine. That's correct. Okay, so slam. Okay, so here the hip flexion is around like 20 degree only. Okay, so this one is slightly in. Is it like we have to follow the procedures and only you can able to adapt this position. So just find the trunk to be get, so just make the neck to also to get bent and place it, and then stabilize the trunk. Okay, and therapist, what you have to do is you just try to stand like this, and then initiate like this. You have to bend like this, and then you have to initiate. You see here, my elbow is being maintaining the leg in plantar flex position. You see here, maintain the plantar flex position. You see here, I'm just going like this. Do you feel any stretch? All right. So he's able to have a good flexibility over the femoral structure because the hip is around like 20 degree only. So you see here. So I can go and catch it like this. You can see here. So then I just maintain the postures and then come to do this. So even if you like, you just go to 20 degrees of maintaining. Do you feel the stretch now? A little bit? No. Okay, that's fine. This is fine. Okay, so usually for this, we will be choosing a prone knee bend rather than doing this because it will be slightly in clinical setups, it's not easier to get to. But for theoretical aspects, still it is there, availability is there. Some patients, if they cannot able to go for prone lying, for them we can do this. Some patients cannot lie in the prone lying, so for them it will be more comfortable to gain on that. So that's why we have to learn this as well. Okay, and then come for long sitting. So this one we are checking for side lying. We are checking for femoral nerve. Okay, so the femoral nerve is more commonly seen among. Have you heard about the conditions like myalgia paresthetica? When you talk about nervous system, you have maybe a clinical picture. You have heard about this. If the anterior parts of the thigh, so the subject will be having an anterolateral thigh. There will be a pain symptoms. Okay. Mostly, it commonly happens in they are doing intensive exercises. Okay, athletes they used to commonly get this. Okay. So now long sitting slam. So long sitting slam is we just try to maintain the same. It's like only thing is here the knee is extended already. Okay. So hip is also flexed, knee is extended, and you just try to make a subject to go for slump positions by holding the hands behind. Okay. Just hold the hand behind like this. Okay. Then just try to go for slump position. Okay. So this one you cannot able to go more than this. Okay. Just relax. Relax and do it. Okay. So this is actually looks like the same structures will be getting involved in that. First one, sciatic nerve, it's like intervertebral disc, okay? So now I'll say like the spinal cord, okay? Compressions or it's nerve roots. So same structures, but only thing is the position is differs. Let's say like if a patient cannot able to go for high sitting position, they are in the bed, then you can test this. You got it? Same structures, sciatic nerve. Okay, so they have a radiating pain. So let's say like when you do this, so the compression side could be a radiating symptoms, or it could be a flexible. Let's say like if there is less flexible, then give you the let's say like the stretch pull on the whole nerve length course. They will be telling like my pain is going from here to back to the feet. Okay, so like that they will be responding. Got it? So these are the 4. Okay. Okay. The next is go for prone knee bend. So prone knee bend is, so we have 3, okay, 2 are prone knee bend and 1 is prone knee extension. Prone knee extension, okay. So can you place your face the other side? Okay, lie down. Okay, so for prone knee bend, so we have to come out with, okay, so can you face this side. Okay, the face has to be get rotated towards the testing side. Okay, so I'm just going to test on this side. So when I want to test on the other side, I have to make him to get to the other side. Got it? So prone knee bend, they have PKB1, PKB2. Okay, so first one, they have to check for the femoral nerve. So this one is actually you have to come out with, okay, so there is a knee bend. Okay, so only the knee bend. Okay, so if there is a tightness, you have a quadriceps tightness, is it? You're lifting your pelvic up. Your rectus femoris is tight. Okay, so if you do this, do you experience any symptoms over there? Alright. Okay, so the nerve is flexible, so that's why he is not getting any symptoms. Okay, so we are testing for the femoral nerve. So the femoral nerve, when you look into it, it is being get around the upper segments only. So we can able to get this. Okay, so the next is Brownie band 2. So that is we are testing for lateral femoral cutaneous nerve. So this lateral femoral cutaneous nerve, when you want to test, the same procedure, but around with this there is an extension and adduction. Do you feel the info? Yes? Yeah. So that nerve is stiff walking. Okay? You got it? So head is rotated to the same testing side. So I am just doing on one side only. So that's why I am just meditating it. Same procedure. So add on with this extension the hip and just go for an adduction because the nerve is more laterally. Say like lateral femoral cutaneous nerve. You got it? Got it? Okay. So this is PKB 2. Okay. The next is pro knee extension. So here there is no knee bend. So that is we are testing for saphenous nerve. So saphenous nerve is over here. So what you have to do is you try to go for it's like hip extension. Okay, just abduction, and we just go for just go for lateral rotation. So when you do the lateral rotation, be careful. So imagine what is in the long lever. So how it is being rotating over here. So it's a like the femur rotation. So it's a like lateral rotation. Okay. So lateral rotations. Okay. And then during these procedures, so then we also can add up with the knee extension with dorsiflexion. So that will help you to give you the clear picture on the nerve over here. Okay. So this was the PKB 2. Sorry, PKB extension. Prony extension. Okay, so these are the 3 testings we'll be doing for. So that's, first you try this. You'll go for SLR. SLR will have 5. Okay, first you practice this. Yeah. 4 plus 3. First practice on this 7. I'll just come back to the SLR. Basic SLR test before. Normally in clinical settings, what? Okay. So until 70 degrees. Okay. So we'll cancel for any neurological movement. So after 70 degree, you go. So when there is any pain or responses, then it will be a muscular movement. So like that only we will be doing that. Okay. So this is the basic one. So now we are just going to add up the. Is like neurodynamics is something like we have to come to the each components, right? So this one we'll go with the distal to proximal components. Okay, distal to proximal components. So how we can able to do is, so we have to maintain the dorsiflexions in the leg. So what we do is we try to maintain this. Okay, so you try to maintain the stability. Okay, then you just see here, you can do this. Okay, okay, so it is much flexible over here. So basic one, you see here, the dorsiflexion. Okay, knee is an extension, and then we're just going for hip flexion. So we can add also there is an adduction, hip adduction as well. So now you have right response. Okay, so when you go, so first you just maintain the dorsiflexion, you just stabilize it, and with the knee extended, you just go for flexion. So when the flexion, he is fine. When I add the adduction, he has the response. So then it indicates like there is a neurological symptoms are there. Okay, so that's what how we can able to do this test. So while doing this test itself, what happens is, okay, so you see here with the dorsiflexions, with knee extension, you just stabilize it, and then when you do, okay, while doing this only the flexion only, that time, if a patient responds, there is a pain is going over the other leg. Instead of I just doing on the right side for him, but he will be reporting as I have a pain in my left leg. That indicates it's a cross leg. SLR.
Right leg got no pain.
Right leg no pain.
What?
Okay, so this will be happens in patients when they have some disc prolapse. So that's why it is a SLR 5. Cross leg SLR. So you can check. So when there is a nerve root discompressions due to disc prolapse, then there is a high chance for cross leg SLR 5. Okay, when you test on this side, opposite leg will be asymptomatic. You got it? So when you talk about back pain patients, when they have disc prolapse patients, for them the symptoms will be like this. It's clear? Okay. So this is SLR1 and I have connected with cross leg SLR also. You got it, how it will be. The next is for SLR2. The SLR2 is for tibial nerve. So the tibial nerve, so when you do, so distally when you, what are the things you have to focus? So we have to go for foot dorsiflexion. So with forward birth, there is an aversion, okay, and also there is a toe extension. So we have to go with all those movements. Okay, so maintain this. So then we just go with knee extension, and then we just go for flexion of the hip. Do you feel any symptoms? Yes, where is the symptoms? Behind the legs. Yes? Here, right? Yes. So that indicates the tibial nerve. So dorsiflexion, foot eversion, toes extension. With maintaining that, we just maintain the knee extensions and lifting the hip for flexion. You got it? You got it? Okay, so that like this we have to go. The next is for sural nerve. The sural nerve is over the lateral side. So we have to go with, so there is an, actually with the dorsiflexion, so we add an inversion in the foot. Rather than eversion, we do inversion. With the inversions, we try to do the same for hip flexion. You have? Yeah. So we have the, so like symptoms. Okay. So it's a dorsiflexion with inversion.
Knee
Okay.
extension.
Yeah. With knee extensions and flexion. Okay. The next is for common peroneal nerve, SLR4. So common peroneal nerve was also it's over the lateral side. So I'll say like here, the foot is going for plantar flexion and inversion. So it will get maintained like this. Okay. And then we just go with the extension with the knee and then flexion, and we'll be going for medial rotation. Medial rotations in the hip. Add medial rotations in the hip. Do you feel it? Lower legs, right? Around here, right? Yeah. So all he is able to give the symptomatic line. He can able to give. So that is how we can able to test for SLR4. The cross leg is, so as I mentioned now, so maintain the dorsiflexion. Okay. And with this, we just do this, the patients will report over the other side. Here, don't have right. If they have the other side, then it will be cross leg. Okay? Got it? Okay, practice first.
So the first SLR one is for which nerve? Sciatic nerve.
Yeah, sciatic nerve. And it also could be positive in tibial nerve also sometimes. But we have to counter check with the SLR2. Okay?
Double check with SLR2 lah.
Sorry?
Double check with SLR2 lah.
Yeah.
Okay. If SLR1 got pain, then SLR2 no pain is sciatic nerve.
Yeah. Okay, try first. Once we just try, so we can choose a distal end and also the proximal end. Okay, so here distal end we have it over here, the ankle, okay, and the proximal is knee, and also we can go with the hip. Okay, so let's say like if he has the symptoms in straight rise, so he's having the symptoms, then how we can keep him exercising the distal segments. Okay, so let's say like we make the angle duplicate free. Okay, so we already tested. So assume like we are tested. So we just maintain the hip in flex positions, and if you want to take an advantage of adduction position as well, okay, then what you have to do is, so dorsiflexion is going to increase the tension in the foot. Okay, nerve. So what you have to do is, so advise him to go for, can you do a pushing actions in your leg? Okay, down, push down. Okay, up. Okay, down. Okay, up, down. So is there like one hand sliding? So from the position, resting position, we are just going for plantar flexion and then like this. Okay, so we also can add up with two ends. So this is one end. So we can add up with two ends. So can go there. We plantar flex and then go for flexion there. Flexion the knee. Okay, so that will relax the structures. You got it? 2N. So we can go with the different aspects. So when you dorsiflex the ankle, you flex the knee. Can you do it? Dorsiflex an ankle? Yes. At the same time, you flex. You both together simultaneously. You flex and do dorsiflex. Now go back to Go back to position. You got it? See here. So this will help you to get glide the nerve. Okay. So we can do 1N. We can do 2N in different patterns. So it depends on how the structure you want to mobilize. You got it? You got it? So this is how you can able to do a urodynamic. So say like we have to choose based on the patient's, let's say like condition. Let's say like if a patient is acute, then we have to choose gliding. Only gliding technique. Okay? If a patient is subacute, then we can go for glide and also we can go for tension. So glide is, we can go with, okay, so let's say like when you prescribe gliding exercise, how many times you do? 10 times as one set. So you have to go for 4 sets. 4 sets of exercise. Okay, so we have to do for acute. So for an example, so let's say like we ask him to get to maintain this position. Can you straight? Okay, so can you try to pump your ankle like this for 10 times? Do it slowly. So make sure whether there is a discomfort. So ensure that the patient is comfortable throughout the procedure. After 10 times, okay, so give rest. Okay, then again go for 10 times. So like this we have to do for 4 sets. So this is active exercise. So actively we are just making the nerve gliding. So we also can passive can do. Okay, so why? So holding like this. So now he's just trying to put a passive force. So we can able to grip the foot and we can able to do for dorsiflexion. So not go for dorsiflexion. So dorsiflexion, if it is go and you did not put a structure on the nerve. Okay, so we can go for the starting point where the patient is being get placing. So from that you can go for glide. Yes, good. Okay, go back to where you start. Okay, do it 10 times. Okay, so you feel the pull in the structures? Yes. So you are just confirming the patient. So you are doing the tension technique. You got it? So you can ask simple terms, where is your response, signs and symptoms. You got it? Do for 10 times. Okay, so what you have to do is, you do 2 sets of plantar flexion, 2 sets, 10 each. Then do dorsiflexion in subacute stage. Okay, so you should know what is acute stage, what is subacute stage right now. Correct? You don't know, right? Yes. Okay, in chronic stage, then you can go for tension technique. Okay, got it? Got it? Okay, fine. Okay, can you come for sitting? So this is the one example you can apply for all the nerves. Okay, so go with the components. Let's say like if a component of nerve is adding with eversion, inversion, we have to work on that. You got it. For an example, straight leg rise, we have for tibial nerve. What's the tibial nerve? What is the movements?
Dorsiflexion, inversion.
Dorsiflexion with eversion. So then eversion to dorsiflexions we can add the gliding technique. You got it?
Plantar flexion, inversion.
Yeah, so like that we can able to go. So always look into the component of motions what is being there for the particular nerve. Okay, so now we're just going for slump, slump positions, how we can teach an exercise. Okay, so let's say like if the patient has a sciatic nerve is already involved, then how we can go is, so let's say like here we can go with the proximal segments and distal segments also get moved. So first we just talk with the one area. So let's say like we try to go for plantar flexion the foot. From the neutral position you just go for plantar flexion. Do it. Okay, 10 times. You can do this. 1N sliding. So for 2N, again the similar patterns like this. So you have to straighten the knee and plantar flex. Okay, and when you're coming down, dorsiflex the ankle and knee flex. Do it? Yes, that's good. Can you do it again? Do it. Count 10 times and do it. Okay, got it? So this is how we can able to mobilize the nerve distally. Okay, so you want to combine it with the proximal structures. What you can do is, when you extend the knee with the dorsiflexion position, you extend the knee. In the dorsiflex position, you extend. Okay, you look up at the same time. Okay, now down. Okay, look up. There is a neck movement. Should be there's less movement you're doing in the neck. You have to do extension. Yes. Okay. Look down. Okay. Up. Yes. Come to the neutral. Yes. Okay. Do it again. Is it discomfort for you? Okay. Right. Okay. So this is actually a gliding. We are just doing in a proximal and distal. Okay. Tension. So do the same. Instead of extending, you flex the neck. Do it gently. Go ahead. Do you feel the stretch? Yeah. So this is a tension technique. You see here? You got it? You got it? This is a tension technique. So the repetitions are all the same. Okay? Do 10 times, make it as one set, perform for 4 times, 4 sets. Is it clear? Okay, this goes for the prone knee bend also same. Take the position and do the same thing. Always take the structure to the end, that is a resistant point or pain point. Then from that, you can go for techniques. Don't force beyond that. That is go for tension. So away from that, you are just going to glide the nerve.